So next we have this interesting talk by Dr. Mordi, which is on biomarkers and diagnostic innovations in AKI. Dr. Mordi is a consultant pediatric nephrologist in Birmingham Children's Hospital, UK. Unfortunately, he could not be here with us, and he
Good
has sent
morning,
us a
and
recorded video of the same. And to chair the session, I would like to invite Dr. Kaustubh Choudhury. He is senior consultant in pediatric intensive care unit in Apollo Multispeciality Hospitals, Kolkata. And Dr. Pratiksha Khatwa, she is assistant professor in the Department of Pediatrics and a pediatric infectious disease specialist in Institute of Child Health, Kolkata.
I imagine that you've had quite a few talks from AKI already, and I'm going to touch a little bit on this really exciting field of biomarkers. And of course, we've been hearing about urinary biomarkers or plasma biomarkers for a long time. And somewhat sadly, I think a lot of these haven't really materialized in the clinical arena in the same way that I thought it would have been, 10 years ago or so. So I just wanted to take the opportunity and touch upon a few slides as to where we are. But I'd start off just by talking about a case which is very common to all of us and which I had the experience of being involved in not that long ago, which is a 4-year-old who underwent a stem cell transplant at our institution for a relapse AML condition and was receiving chemotherapy for the induction and also the usual protocol with antivirals, and noted to be having an elevated creatinine. And we had a consult which was placed to the renal team, as is normal, and we gave the usual advice, which is, make sure you've got the fluid optimized and adjust the doses of the medication and to stop the ones which are not necessary. But in spite of everything that we did, the creatinine continued to rise. And actually, for something which started off being not really quite significantly, we found ourselves in a situation where the creatinine kept on rising, and we felt somewhat not really able to predict where this was going. And some of the questions that we probably had at that time was, what would we need to do in order to give the correct management? If we'd had a biomarker to predict to which extent this was going to progress, it would be really important in sort of how we would advise. As it happens in this particular case, in the end, thankfully, things started to reverse in spite of what we did, and didn't end up going on to requiring renal replacement therapy. But being able to predict that certainly would have been something extremely useful from our point of view. So with that in mind, if we look at the urinary biomarkers, which we have at the moment, and certainly which we had for this patient, they're really what we use very clinically is basically using the serum creatinine and the urine output. And we've heard a lot of how amazing urine output is, and there was a paper published a number of years ago showing that actually if you could predict in the sort of AKI rifle that someone's urine output is dropping in the first 6 hours, then that is really the time when you want to intervene, which I think is really very useful because it's really very simple and cheap test. But the problems with urine output is that it's not always very easy to measure it. It sounds easier said than done, particularly in a child. So we have these measurement errors. Sometimes it can be changed depending on whether they've received a diuretic. So we have it's manipulated by diuretics, and also physiologically, you might have a child who doesn't want to drink very much or whatever the case might be. So it is subject to those degree of errors. And then serum creatinine is obviously what we use most often, and we also know this fallbacks with that, in that, it's very much affected by muscle mass, by what you've eaten in the 6 hours preceding that. There's a lot of analytical variability, particularly someone who's already got a background of a low GFR. And it can be inhibited by a number of drugs, trimethoprim being one of the typical ones. Levamisole is another one, but essentially, which brings about a rise in creatinine. And you can also mask it. So if you've got creatinine which is going up and you give lots of volume, the creatinine may look as if it's coming down, but if you've actually got some real renal injury, you could actually be masking the fact that the creatinine is down, whereas you're not necessarily bringing about any improvement in the condition, even though you might be setting up conditions for the improvement. And then there are other drugs which can affect your creatinine, like the renal aldosterone, angiotensin aldosterone inhibitors, and those which work on the SGLT2 pathways, which could effectively increase your creatinine from that point of view. For patients who've got AKI, obviously you've probably had talks about this, about the various things, and why it's important to be able to know which of the biomarkers to use is because if you have very early biomarkers, then you can make a very early detection of what's going on. And if you could detect things early, then you would hope that you're able to be in a situation where you can put in an intervention. And if you've got early management, what you could do is to do things like avoiding nephrotoxins, to identify the causes. It helps you select the correct drugs which you're going to use and the correct drug dosing. And if there needs to be organ support, then you may want to institute that early, particularly in children who are receiving quite intensive therapy, where you don't want them to get into a situation of fluid overload before you really start to intervene. So there is a lot of reasons out there for which it's really important to be able to have an early biomarker, because it would largely affect the management of the patients that we look after. And so a lot of the traditional methods of detecting biomarkers have been largely detected from either the pathophysiology which is thought to be suspected, or from which part of the glomerulus or the nephron pathway which is deemed to be affected. And so if you take that walk along the nephron, you could think of a collection of biomarkers or biomolecules which are secreted by various parts of the kidney, be it the glomerulus or the proximal tubule or the ascending loop of Henle or the collecting duct. And so a number of biomarkers have been promulgated, whether it's the lipocalin, the NGAL, the fatty acid binding proteins, the interleukin 18, the chemoattractant proteins, the metalloproteases, whether it's the kidney injury molecule, the insulin growth factor binding protein 7, but they all have different parts at which they secreted. And if you were thinking of an ideal biomarker, then one can think that potentially it would be useful to have one out of the various areas which might give you a general view. Another way also of looking at the biomarkers, which could bring about a constellation in order to work from, would be to also look at those biomarkers which are involved in renal inflammation, renal repair, and oxidative stress. So the other ways is to sort of think about these other biomarkers, some of the ones which we've already mentioned in renal tubular injury, which will be increased, but looking more at those interleukins, which will increase in times of inflammation or in repair, looking at the repair or stress responses like TIM2, and a little bit more to be discussed on TIM2 and insulin like growth factor binding protein 7, or the netrins, and also those which could be indicative of oxidative stress would be a useful biomarker. And if you look along the actual injury which occurs in acute kidney injury, there is a tubular cell perspective, is that you could have the capillary, these are the tubular lumens which are indicated here. When there is an injury to the tubular lumen, there is a period of the initiation of what causes the problem, and then the extension, which could be driven by from cell injury to the hypoxia, and the maintenance situation of the dedifferentiation, and then you get to the recovery. And all along this path, there may be various biomarkers that get secreted, which can give you some indication as to where you are along that journey, as to whether one is at a recovery stage or a maintenance phase or an extension phase. And these could be a useful way of thinking of a biomarker which one wants to measure to see where one is along that path of the injury. And if you are thinking of the sort of progression of AKI, from AKI to acute kidney injury to acute kidney disease to chronic kidney disease over that 90-day marker, then having different biomarkers that tell you things at these various points would be very useful in telling you which way along the pathway one is really progressing. And in addition to those biomarkers, what would be useful is to have a constellation of risk factors, looking at things like the renal angina index and other biomarkers, which can be put together with the investigations that we have and help towards making a diagnosis and seeing what's the risk stratification for patients who've got AKI to progress onto CKD. And this is something which could be effectively very useful from that point of view. And if we understand this process, then we can understand the various things which we can put in place in order to mitigate it, such as the educational program, avoiding the mitigation of the insults, and being very careful about how we manage the drugs that we give, the nutrition, what sort of fluids we give, and more on this is to be also discussed later. And if we look at a number of biomarkers, if we look at the creatinine, which is shown here in purple, in patients who have AKI, you can see that it does rise, but if you look at the x-axis, which is in hours, the rise of the creatinine is rather late from when things occur. Whereas some other biomarkers, and these are patients who've undergone surgery, tend to perform a lot better, like the NGAL, which would rise much early on and falls from the time afterwards, whereas the creatinine, you start to see the rise even after the event has occurred. KIM1 is better than creatinine in terms of its rate at when it peaks at, and cystatin C also is better than creatinine from that point of view. So it's useful to know in general where these biomarkers look or compare to in terms of others. And I can't stress the fact enough that what we really want to do is to be able to have more of these pre-injury phase biomarkers, because that's really what's going to make us put in an intervention much earlier, even though it's obviously important to have some of the damage biomarkers, because that's really important to know what we would need to do in order to intervene if required. Two of the biomarkers which were discussed quite a number of years ago, and we really thought there was going to be quite a lot of success with these, was the urine insulin-like growth factor binding protein 7 and TIM2, and they had performed much better than the existing biomarkers. And these were inducers of the G1 cell cycle arrest implicated in AKI. And it was felt that if you looked at the tubular cells, if in the cellular level, both this TIM2 brought about the induction of these P proteins such as P27, whereas the insulin-like growth factor binding protein 7 induced both P21 and P53. And those P21 and also P53 by induction of P21 brought about an arrest of this CDK2, and equally the P27 brought about a reduction of the CDK4. And we know that this then resulted in a G1 phase cell cycle arrest in terms of the tubular health and stopped its proliferation. So these were biomarkers which were at the time touted. There was a kit which was out, and we were all very excited and thought that we would have something which we would be using clinically in addition to what we had. But in real terms, I have to say this isn't something which has really materialized, at least not in our trust. We're not all measuring the TIM2 and the insulin-like growth factor binding protein 7 levels. So the hope so far is that this might be something which is eventually used in a clinical state so that it could be useful. The other biomarker which we also worked on quite a lot on was the NGAL, and this is also called lipocalin-2, and we know that NGAL was when you don't have AKI, then the levels are usually low, and even at levels of when this serum creatinine can be normal and the urine output is normal, and you have a subclinical AKI, you can start to have an elevated NGAL. Equally, when the serum creatinine is actually up, you still and that you have a functional NK with a reduced EGFR, then you can have a low NGAL, and this could be a stage of potentially either recovery or there is really no damage. So your creatinine here could be calling it as if there is something, but it could be one of those other situations where it's just, they haven't had enough to drink or whatever the case may be, but not a full-blown AKI. So your NGAL is much better at distinguishing between those, but the NGAL would be up when there is obviously an established AKI, reduced GFR and tubular damage, in which case your serum creatinine will also be up. Here again, I think the NGAL story is one which is still developing and emerging, because we still haven't as yet seen it as a day-to-day clinical use, although I know that it is used in some other places, but we're certainly not using it yet. And then with the urinary biomarkers, it's probably worth saying that there are, apart from the proteins which are involved, there are also the technologies which have made or which will make these biomarkers something of great interest, because in addition to the soluble proteins, some of which we've discussed and those involved in inflammation, and some of the metabolites which can be seen, there are other biomarkers, particularly the urinary biomarker arena, where we could also look at the RNA and the messenger RNA and the extracellular vesicles and other RNAs. And this is something which could potentially be very interesting and used clinically going forward, but it does need a lot of technology with it, some of it which will be in addition to the ELISA, but some of it may require also using the resonance and NGS technologies. So it is something which is definitely coming along, but would be useful to see as it evolves. One of the other biomarkers which I touched upon earlier in terms of inflammation is the CXCL9. And I've only just put this here not just because it's a urinary biomarker itself, is because I also came across this interesting paper which puts this as also a diagnostic marker of acute interstitial nephritis. Now, this is something that we see very often, and we would make a diagnosis by undertaking a kidney biopsy. And one of the useful things about having urinary biomarkers, not just to say that the acute kidney injury is at the initiation phase or at the middle phase or at the recovery phase, but it would be also useful in order to have some more diagnostics from a urinary biomarker. And one typical case is where the creatinine goes up. We're not really sure of the cause. We think it might be likely an acute interstitial nephritis. We can only make the diagnosis by undertaking a biopsy, and then we can treat it by giving steroids. And it would be really great if we had a biomarker which could not only mention that this is AKI which is progressing, but also could tell us that this is what the diagnosis is likely, so we can institute treatment without the need for an invasive test. And this group here used highly multiplex proteomics and identified CXCL9 as a biomarker for acute interstitial nephritis, which they were able to validate this. And they looked at the expression also in tissues in those who've got acute interstitial nephritis, and looked at the people who had undergone biopsy from a cohort and tried it out in a validation cohort after they had tried it in a discovery cohort, and identified it as a potential diagnostic biomarker of acute kidney injury. So there's lots of things which we can do with biomarkers in terms of being able to find out the phase of which we are from injury, and also being able to use potentially the biomarkers to do a diagnosis. But it is a long way ahead, as it were. And so, in conclusion, there are lots of novel biomarkers out there, and they can predict the AKI development, and we want ones which are earlier than creatinine, but they do require rigorous analytic validation before we can really get them promising candidates, before we can put them down for the clinical use. I think if we have a biomarker, we can use serial assessments, which can provide dynamic insights into the progression or the resolution of AKI, but we will still remain with some uncertainty as to where the optimal cutoff values would be for whichever urinary biomarker which we effectively decide to use. So that's all I was going to cover from the point of view of this urinary biomarkers, but I'm happy that if there are any issues or questions to be taken. Thank you very much.
So,
Okay, next we have a talk coming up on how to follow up children after AKI, and that is by Dr. Rajiv Sinha sir. He is professor and HOD in the Division of Pediatric Nephrology in ICH Kolkata. He has innumerable publications and achievements. And to chair the session, I would like to request Dr. Rana Shaha and Dr. Swarnim to please come over the stage. Dr. Rana Shaha is consultant pediatrics with special interest in pediatric nephrology in Manipal Hospitals, Kolkata and Dishan Hospital, Kolkata. And Dr. Swarnim is associate professor in the Department of Pediatrics and Division of Pediatric Nephrology in AIIMS, Patna. Over to you, sir.
So in the morning there was this question by Agni about AKI and how many of them develop CKD. So we will try to deal with this question, and maybe we will be able to convince a bit the non-believers. So we have got this case scenario, standard case scenario of a child requiring KRT, blah blah blah, but everything is improving and creatinine at discharge is 0.5. So if the child is under Agni, he will not ask ever to be followed up in the ICU, and maybe he will even discharge the child, telling the family that everything is okay. So that's what we should be trying to say, that whether we should be following up post AKI children or not. We will maybe go through the why, when, and how. So why? Now after AKI, number of things can happen. Your kidney may never recover, your kidney can recover and again have a secondary hit, or your kidney can recover partially and stay at the CKD. So all those things, all those lines can happen. In the we also heard about Ahmed's talk about the AKD, and it's important. So this is now well known that after AKI, it is not that always your kidney will be recovering completely, and there are physiological basis of progression of AKI to CKD. If you remember that what happens in like if the insult is very bad, you are losing some glomerulus, and that will result into the other glomerulus working more, and nobody wants to work more. You do get tired if you are working more, and there is a chance that you will be having the what we describe as the hyperfiltration and its consequences. During AKI, lot of things happen, lot of phytokines, etc. are released, and they can cause a lot of interstitial inflammation, and that interstitial inflammation can result into fibrosis. What has been shown is that during the AKI process, all these cytokines may be useful, but ideally it should be switched off once the thing is resolving, but often this is not switched off. If it is not switched off, then your fibrotic processes goes on. What also has been shown that during this AKI process you can have endothelial cell injury, and because of the endothelial cell injury, and if they don't recover, then your blood supply continues to be less than before, and that can also cause your progressive damage to the kidney. So we do have quite a lot of evidence that this does, like from the physiological basis, that this does or can happen, that AKI resulting to further CKD. So I'll skip all those two slides because I've already sort of made it simple, but I've already discussed that. But what about the clinical evidence? Again, this is nothing new. This is a very old article from NEGM 1956, and where they showed in adult that if you get a hit, all of them don't recover their kidney function. Some of them will not. And in adult, there are big meta-analysis. People usually refer to this Coca et al. Meta-analysis, often showing that post-AKI there is a adjusted risk of CKD is very high, 8.82, and end-stage renal failure 3.1. Risk of CKD after AKI. But then we always say that children are not adults. So what is the evidence in pediatric to convince Dr. Agnisekhar Saha? Why should he be asking all these questions? Why? Because, as I said, children are not adult. He knows that the AKI etiology in children is quite different from adult. In adult, it is primarily like you have an underlying some sort of etiology. Some cause of bad things like diabetes, etc. The primary cause of AKI in adult is also often different. Comorbidities in children, fortunately, are less, and ideally we should be having a better reserve and a potential for recovery. So Dr. Agnisekhar Saha is 100% justified to be asking these questions. This was among the first pediatric study way back by Dr. Ashkenazi's group in 2006, and it got published in Kidney International, which even at that time was a high impact journal. Now I think it's about 15, 20, something like that, the impact factor. And if you look into the study, they were able to follow up only 29 children. Only 29 children they were able to follow up at about a variable of 3 to 5 years. But even then, they got into the Kidney International. And what they found was that yes, out of these 29 children post AKI and who had survived, about 59% of them had at least one sign of chronic renal injury. But as I said, a lot of drawbacks, no control group, uh, I think more than 50% lost to follow up, non-standardized definition of ARF, but a KI publication. We, Dr. Abhijit Travada was there yesterday. We, along with Travada sir, published our study in NDT, another quite a high impact journal. But then again, it showed quite a significant percentage of AKI progression to CKD. But again, very small number, no control group, 8 out of 24 lost to follow up. So not really very good, strong evidence. But because of the scarcity, I think it got published in the high impact journals. It was Cherry Mamin. I'm sure Ahmed knows him, and a very close friend of mine with whom I worked in Vancouver, who first came up with a prospective study, prospective 2-year sort of a study. And he also showed in this study that yes, the AKI from PICU, they do have a higher chances of moving to CKD. And overall, the incidence of patients who develop CKD after an episode of AKI was 13 of 126, so 10% of them. And at risk of CKD, so CKD, when you CKD is one, and at risk is like having hypertension or proteinuria, that was a higher, about 46%. So at the end of the follow-up. But again, this did not have a control group. So this was a meta-analysis that was done around 2015, and what they decided was that no, we will not do the meta-analysis because we don't have that much of evidence. So they sort of reduced it to a systematic review. And again, the conclusion was that yes, AKI does move on to CKD. But if you see that it was only Cherry's article which was prospective. All of the rest was retrospective, and most of them had very small numbers. But something more has happened in the last 5-10 years. Many people will be knowing this name in pediatric nephrology, Rahul Chanchalani. He is from India, but now well settled in Canada. He and his group came up with 2 fantastic publications in JSON, just using the Canadian cohort. And in Canada, there is a insurance system, so it was easy for them to get the data. And big numbers. So first one was about in the thousands number. And what they came up with was that if first they published if the child was having dialysis, and this was Agni's question that okay, dialysis progressing to CKD makes sense, but non-AKI, just AKI but not having dialysis, will that also go to CKD? Doesn't make sense to him. So the first was dialysis, and here they clearly showed that about 1,688 children, and they had a control which the previous studies didn't. But they showed that yes, if you are on a dialysis, you have a high chances of moving on to CKD. And then just trying to answer Agni's question, I am not sure whether they knew about this at that time. They came up with what will happen for those who were non-dialysis, just having AKI, and there also, as you can see, there was a higher chances of CKD. So these were really big studies, big numbers, retrospective but big numbers, and really I think made the evidence stronger. But we are still lacking big prospective number, and the other thing we are lacking is studies from India. So our own group came up. This was a sort of a pilot study of one of our PGTs, MD thesis trainee, and this got published in Pediatric Nephrology early this year, where we also showed that yes, post AKI from the Institute of Child Health PIC unit, there is a higher chances of children moving on to CKD, AKD and subsequently CKD. So from a low, about 25% with AKI died, 38% of the survivor who had AKI persisting for more than 4 years developed CKD or were at risk of CKD at 3 months. So quite a good number. And unfortunately, Dr. Agnisekhar Saha also works in that hospital and is contributing a lot to the PICU. So a large percentage of those children are ending up with CKD and or AKD. So I think this one most probably we have settled quite a bit that yes, AKI can lead to CKD, but definitely we need more studies on it, more prospective studies on it. But more or less, most of the nephrology community, not even pediatric adults, are convinced that AKI can lead to CKD, and that has got outcome problems. That has got, like, it has been shown that there is a decreased quality of life. That has been shown that there is an increased morbidity for those AKIs like who have been followed up, and increased mortality also. And with all those things, the KDIGO has come up with the guideline. Unfortunately, like, it is a kidney society, and maybe other people may not follow it, but it is a quite a reputed society. So the neonatologist and pediatric intensivists should be following it up, and obviously they can review the evidence based on it. That they have come up with the guideline that all AKI, not children, adult, anything, all AKI should have at least a 3-month follow-up. At 3 months, you should be looking at blood pressure, urine, and creatinine. If the urine shows any bit of proteinuria or the blood pressure is high, then they need a long-term follow-up, ideally with the nephrologist. And this is that was the KDIGO guideline. The NICE guideline also says the same thing about the need of monitoring post AKI. Why is this monitoring important? Number of things can be done because of this follow-up. Number one is that you can educate the family about the need for avoiding the nephrotoxic medication. Number two, blood pressure control. Blood pressure control is a good thing. Even adults agree, we agree. So that is also reinforced. If there is a proteinuria there, you can start the ACE inhibitor earlier, and we all know that proteinuria is not good for kidney. So all of this can be a useful thing and can be one of the ways where we can maybe decrease this CKD epidemic that has come up. But for us in pediatric, it might be slightly easy, but in adult, it is very difficult. If they start up following up all their ICU graduate in adult, I think Arpita Di and rest will be overwhelmed. Even in their private practice also, maybe they will not want all the ICU graduate to be followed up. So, is there any pointers? Unfortunately, in pediatric, we don't have much, but in adult, they have found out. For example, older age, hypertension, cardiovascular disease, anemia, AKI, having recurrent AKIs, having albuminuria, history for the KRT. Those are the situations where they may be needed to be referred to a nephrologist, and that even in that in adult is a huge number. And justifies even in the private practice also, they will be quite happy. What about pediatric? In pediatric, we don't have a strong evidence, but there is this paper, anyone interested can go through it, where they found that yes, even the importance of proteinuria for the follow-up. And we did in that study which we were referring to from our institute, there also we found out the importance of acute kidney disease, again referred by Ahmed this morning, that AKD. So AKI, AKD, CKD. AKD is abnormality persisting beyond the 2 weeks time, 7 days, 2 weeks time. That is the AKT till the end of 3 months. So this AKT phase definitely has to be followed up. And in AKT phase, first of all, it has to be identified and then it needs to be followed up. Why? Because you can do lot of intervention during the AKT phase, acute kidney disease phase, like controlling your blood pressure, avoiding nephrotoxic agents, those sort of things. And this has been shown by retrospective studies, but has been shown that the AKT phase is very important in pediatric also. So in conclusion, we can say that follow-up care should be offered to all patients who have suffered AKI. Patient with obviously elevated baseline creatinine with incomplete kidney recovery or with proteinuria would be prioritized to be followed up by the nephrologist in the resource limited places. So answering the Agni's question, does our child needs follow-up? Hopefully he should be saying yes now, and in future hopefully he will be following up all the cases of AKI that he sees in the ICU without referring to us. And at 3 months he should be at least doing a creatinine and a urinary and a blood pressure. Thank you very much. I tried to be quick so that we can save some time. 2 minutes, not much I saved. So thank you, and remember follow up. Thank you.
Thank you, Deblina. So today I have the privilege of introducing and welcoming two of my colleagues from pediatric intensive care and two of my colleagues and friends from pediatric nephrology. Ma'am, please take a seat. We already have 4 chairs, right? So can I have Dr. Abhishek Poddar and Dr. Kaushik Maulik? These two are experts from the pediatric intensive care and very closely related to our pediatric nephrology branch when it comes to dealing with pediatric AKI. Sorry. And then we have Dr. Sumantha Roth and Dr. Shubhankar. These two are my colleagues from pediatric nephrology. Sorry. So why to prevent acute kidney injury in children? If you look at the basic conceptual model of AKI, when we diagnose AKI, it's only at the time when the IGFR is reduced, and that is the time we normally clinically diagnose AKI. But then what we really miss are the earlier opportunity and the therapeutic window that could have been applied if we really look into it earlier on. And to do that, we need to have certain identifications and risk factors, stratifications, wherein we can deal early on to prevent these children. So why bother? Because acute kidney injury, at least in the developing world, is quite common, especially in hospitalized children. It's preventable, it's treatable, and if they are not managed early on, they can have a long-term bad outcomes, can leading to AKD, as we discussed, can land up few of the children with CKD and eventually death also. So why preventions? Because a lot of children who are admitted in general pediatric unit or even in critically children in ICU suffer from acute kidney injury, and the burden is quite huge in developing this part of the world with huge number of deaths. If you look at the stats, AKI affects around 10% of hospitalized children and up to even 30% of the children in PICU. So mortality rates is also very high, as much as 9 to even 60, above 60%. Now, what should be the relevant question when it comes to preventions of AKI? We need to, how do we identify patients at risk of high developing AKI? How do we identify patients having risk of progressions of AKI to AKD and CKD? How do we diagnose them early and underlying cause has to be ascertained? And how do we identify patients who are likely to benefit by early therapeutic interventions or KRT? So we have had evolutions of diagnosis, more than 35 definitions have been confirmed, and there are evolutions of so many criteria only to find the best of criteria to diagnose them early on. So we might have in future a more enhanced AKI staging, dealing with even cases of subclinical and even thus functional or subclinical AKIs has to be diagnosed. So maybe in the newer definitions which is proposed, we might have we might be including biomarkers, especially when you are grading these, staging these AKIs. As of now, we have a KDIGO guidelines which are widely and most recognized, which are being used. Coming to preventions, ISN has introduced, or rather had a very ambitious goal of reaching 0 by 25 that is the zero preventable deaths from AKI across the world, especially in the developing world. So no children should die at least due to preventable cause of AKI. Now, global snapshot study has said that there are most of the causes are maybe preventable, like dehydration, hypertension, and they form the major chunk of it. Traditionally, we etiological bias we classify as pre-renal, renal, and even post-renal, and this is important to identify these cases and treat. Now, coming to my first question with these basic informations, this is a child who's a 7-year-old child, came to ER with loose watery stools, vomiting for the last 2 days, having decreased urine output for the last 12 hours. The child looks lethargic, have dehydrations. My first question to my pediatric intensive colleague, who are the first one to deal with, is the child at risk of AKI? What are the risk factors of AKI here? And comment of if there is a risk stratification procedure that you follow when you initially receive this child in PICU.
Okay, so the answer to the first question is yes, definitely this child is at risk of AKI because there is history of significant volume loss and clinically the child is dehydrated. So there is a high risk of pre-renal AKI in this child. And if we consider the different risk factors for AKI, so they can be intrinsic to the patient and there may be some extrinsic factors also. Intrinsically, if patient is having chronic kidney disease, chronic cardiac disorder, diabetes, chronic liver disease, transplant patient, or any previous episodes of acute kidney injury, if it has happened, then definitely there is a high risk. And obviously, extrinsic factors like if child had a shock or hypoperfusion, exposure to nephrotoxic drugs, sepsis, volume depletion like in the index case, exposure to contrast agents, and per se if there is a prolonged ICU stay, multi-organ dysfunction, mechanical ventilation, all those things are important factors which might predispose to acute kidney injury. And regarding prediction as to who might develop an acute kidney injury, there are several tools and scores which are available. Renal angina index is one of the most important among them, and they will be discussed subsequently by my other co-panelists.
So identifying all these high-risk cases are very, very important. So that goes to my next question. What are the AKI risk stratification tool that you can look for in these children? Dr. Shubhankar.
So there are many tools already there in establishing process. So on them is a renal angina index that Dr. Kosik want to say actually. Other like the fluid overload score and also some biomarkers. Just in the morning I asked our one speaker for about the biomarker, but biomarker mainly the prediction and kind of thing. So and then other is the furosemide stress test to progress in the higher stage of AKI, and also some AI tool is emerging, looks promising, but still they are all like in kind of process of validation and not in clinical practice. But among the renal angina index, fluid overload score, these are in very practicing nowadays.
Okay, regarding AI, Dr. Ahmed already discussed a lot of things today. So coming back to our case, so this child who came with loose watery stool, dehydration, had a low BP, and then if you could see from here, the urine creatinine was very high, creatinine was 4.2, there was hypokalemia and gas showing acidosis, and there was no urine, almost oliguric, 0.2 ml per kg of urine output per hour. So my questions to Dr. Abhishek. So what should be your initial management, whether you will give fluid, to increase the urine output, vasopressors, diuretics, what would you do initially?
Very importantly is the history, and as we look into the history, we'll see that this child has typically having vomiting and loose motion since the last couple of days, and loose motions to the extent of 18 to 20 times a day, which will typically tell us from the history only that this child is hypovolemic. And the other parameters, the heart rate, the blood pressure, all these point that the child is significantly hypovolemic. And in any hypovolemic child, the first thing which should be giving is fluids. We should not be thinking about whether to give more fluids at this stage, but typically when the child is hypovolemic, you have to give fluids first. Typically isotonic fluids, start off with ringer lactate or normal saline.
Okay, so the first thing is that optimizing the child with fluid and correcting the hemodynamics is the most important thing. When we come to fluid, how to manage the fluid balance in these patients and who are at risk of AKI? And when we talk about fluids, should be less, should be restricted, or whether you're doing too much of it, liberal or overdoing of the fluid therapy? Dr. Koshi, can you throw light on this? How much should be much?
Okay, so sorry. when we are managing these patients, so very important is that to take adequate care of developing fluid overload. So like we can see from this study, the release trial, which was regarding restricted versus liberal maintenance fluid strategy in mechanically ventilated children. So this doesn't deal with AKI per se, but there are many such trials also, including many RCTs and meta-analysis also, which has showed that fluid overload has a direct correlation with the multi-organ dysfunction, the evolving worsening of the pilot scores, and also prolongation of the duration of mechanical ventilation, PICU stay, and also it increases the risk of acute kidney injury as a part of this multi-organ dysfunction. So now the most important is that by fluid overload we mean how much. So when we are managing these patients, like as will be discussed by my co-panelists later, so we have to keep the intravascular volume optimum. Like in the ICU, there are several tools which we can use at the bedside to assess whether intravascular volume is optimum or not. And we should not allow the fluid overload to cross 10%. We should try to take active steps even before the fluid overload status reaches to close to 10%. So as the fluid overload crosses 10%, then what happens is that gradually the fluid starts accumulating in the different encapsulated organs. There is the global increased permeability syndrome or GIPS, and that leads to the worsening of the organ dysfunction. And so also is similar, like in a subset of patients, like the post-cardiac surgery patients, like we know, they often come back from the theater with peritoneal dialysis in situ. So in them, we do not tolerate fluid overload at all. Like from the beginning only, we try to create a negative balance so that they remain euvolemic as much as possible, and then we try to create negative so that this can be prevented. So our target should be to give fluids in such a way so that we do not cause unnecessary fluid overload, and it should not be allowed to cross 10% at any cost. And as soon as that we are close to that stage, if the patient tolerates, we should start evacuating fluids actively, preferably through diuretics. And like in post-cardiac surgery patients, like if they are hypotensive on multiple inotropes, so sometimes from the theater we might need to start the PD. So that is the paracorporeal or the extracorporeal strategies of fluid removal. So that is the main way we should give the volume or fluid in such patients. It should always be guided with monitoring parameters for intravascular volume status, including our clinical parameters and also the bedside ultrasonography and echocardiography.
So very important point raised here is that if oliguria is bad for kidney, fluid overdone is also very bad, equally bad, and always avoid fluid overload. So if you want to kind of in critically ill children, if you want to find a balance, so this is what he has already said, there has to be very much optimizing fluid status, and hemodynamic status has to be very much optimal. So how do you assess this fluid status in children in AKI? Normally, what do you do to assess how much fluid to be given? What are the criteria that you follow in your intensive care unit? Dr. Abhishek.
Again, in any child with, to assess the fluid status, we obviously start again with the history. Very important as to assess what is the exact reason that AKI is happening or has happened. So again, a pre-renal AKI probably will require more fluids rather than someone who is having a sepsis as one of the reasons. Any nephrotoxic exposures, any edema, underlying disease, heart disease, nephrotic syndrome should have a proper knowledge as to why that AKI is happening. Clinical examination, again, we shall be looking into the signs of hypovolemia, such as tachycardia, the typical things we do at the bedside, a prolonged capillary refill, cool extremities, weak pulses, sunken eyes with dry mucosa and hypotension, though it's a late sign. We should look in all of this. Again, continuing bedside measurements, which we regularly do in our ICU, is regularly checking the weight, which is a very good bedside in non-invasive marker. Strict intake output charting, if required, we can do it on a 6-hourly basis. Blood pressure, though a late measurement, but still is very important. Chest x-ray, CVPs are also good, but most important, what is important nowadays is the point of care ultrasound or POCUS, what we are now focusing on. And out of that, the IVC collapsibility index, which we typically see, and if there is hypovolemia, we typically find it to be more than 50%, especially IVC distensibility index in ventilated patients. look for P lines in the lungs, which is a sign of fluid overload, very sensitive marker as well. And nowadays new scoring systems are coming, such as the venous congestion scoring or the VEXA score in older children, which takes into account the not only the IVC but also the renal veins, the portal veins, as well as the renal veins into account. Also, lab investigations, though not very important in assessing, but serum creatinine, urea, electrolytes, the urinary sodium, phenolphthalein are also important markers in assessing the fluid status in patients with AKI.
So optimizing fluid and hemodynamic status management is also very important. So what was my next question to Dr. Shubhankar? So when you're choosing fluid in these children, in any cases of prerenal AKI, obviously you want to give fluid. What should be your ideal fluid? Whether it's a colloid or a crystalloid, a very controversial question, whether VSS or saline, or whether you can give albumin. Is albumin safe also?
So I think the both guideline from the KDIGO, there is a standard guideline. They are saying that crystalloid is better than colloid like albumin or starch to prevent development of AKI and already develop AKI. So crystalloid is better than colloid. And if you see the cerebral sepsis guideline, they are also suggesting to use crystalloid and compared to the colloid like albumin. So, but although there is no difference between the outcome of colloid versus crystalloid, but the cost, availability, and some other factor leads to choose colloid is better than the crystalloid. And if I choose between what type of crystalloid, then just better than, I mean, just choosing the normal saline 0.9% is not good than the balanced salt solution. So if you have a balanced salt solution, then it's better than the crystalloid of 0.9% is a normal saline. So in that way, we need to choose kind of fluid for research in the child, and that will help for management further.
So can you use albumin? So albumin, where does it stand? Like if at all you have to use.
So I already mentioned that the albumin, there is no difference between albumin versus crystalloid, but you see the availability of the albumin and the cost of the albumin, and the albumin is a colloid. So I not prefer in the both the guideline, and it also practice is not feasible to do the albumin in a first setting. So if you have a easily available low cost solution in your hand, then better to use a crystalloid than the albumin in a first contact.
So the key message is use crystalloid, but then there are times the colloid can be used like albumin, especially in cases when you have hypoproteinemic states like in nephrotic syndrome with hypovolemia, wherein we can use a diluted albumin as well, but then again cost factors.
Yeah, definitely. So even some dengue patient also good response with the 5% albumin, and especially in the nephrotic has a hypovolemia because of the hypoalbumin, then it's a definite to choose the albumin rather than the giving fluid bolus.
Right, but again, how fluid overload is linked to mortality and morbidity in the long run. How can we prevent this fluid overload, Dr. Abhishek?
This is also very important that fluid overload has been now, it's being shown that it's one of the indicators that which deals with both mortality as well as morbidity. So fluid overload, which is calculated as a percentage of the body weight gained due to fluid accumulation, and if the fluid accumulation starts, we should keep a daily track on that. We keep a daily management at how much fluid is getting overloaded. So if till more than 5%, it's okay, but keep a close watch. More than 10%, definitely you have to be on your heels, and if it's more than 20%, then probably you have to initiate some sort of RRT.
So how, for the postgraduates, how do you calculate fluid overload, and how frequently you monitor fluid overload to check whether your progression is going beyond the level where you need RRT?
Normally we do it on a daily basis, but in selected cases you can do it on a 6-hourly basis as well, to see if the patient is very fluid restrictive or you are very tight on the fluids. Then you can do it more frequently as well, because as we see that fluid overload, as Dr. Kaushik was already mentioning, the complications associated with fluid overload, which includes pulmonary complications where there is interstitial and alveolar edema stretching the lungs, and hence the need for mechanical ventilation. There could be cardiac dysfunction, cardiac strain, putting more load on the heart. Then there is hypertension causing end organ damage. Again, delayed renal recovery.
So how do you keep the target? Like, what's your target? Like, you have to keep it between this to this and then not beyond this.
We try to keep it at less than 10%. Less than 10%. It's the ideal, which is now getting followed everywhere.
Right.
Is less than 10%.
So fluid overload above 10% can be bad, and you need a decongestion therapy. Right. So nice. So and also there is a high mortality risk which you have mentioned already. So giving too much of saline, be very careful when you're using, for example, if you're using 1 liter of saline, the amount of salt that you're infusing the child per day would be something like more than 20 packets of Lay's. So be careful of this, and it can be a very vicious cycle when you're using fluid overload that will again, rather cause kind of compartment syndrome leading to further AKI. So that can have a progressions to AKI as well. So now the next thing that is coming up in a big way in ICU especially, this is the renal angina index. What is it and how good it is a predictor and having a predicting ability to identify the risk of severe AKI early on? Sumantra.
Okay, so at the outset, I would like to thank the organizer to keep prevention as a topic, because besides the glamorous CRRT and auxiliaries and that and
Prevention
this,
remains
so
the
keeping
key.
it simple. So regarding early prediction, so renal angina index, it's my audacity to talk about RAI in front of Kadura sir, the makers of RAI. So frankly speaking, for our common pediatricians, we can, as a 65 years old, simple language, 65-year-old diabetic grandpa with a chest pain, crying for chest pain, can have a chance of cardiac disease. So when our kidneys are at problem, it can cry, but we can't hear it. So how to hear that? By some points. So we have some clinical points, risk factor, and some already injury point. When the child is admitted in a critical care, we can score it. The scores are of 3 pointers of different scores, 1, 3, and 5 for risk factors. And there are 4 pointers regarding their already injury status in 1 to 8 factors. We have to multiply the things. The scores range between 1 to 40. Lower the score, better is the chance to have lesser AKI in due course. So studies have shown if the scores is more than 8, then there is a high prediction to have an AKI within 3 days with a reasonable sensitivity and specificity. So many of the times it happens that suppose Messi came for playing a football in Calcutta, have a leg fracture, went to medical college emergency for X-ray, and along that 65 years old grandpa came with a cardiac angina, came for a emergency for their TROP-T, and a acute intern did a TROP-T for both the patients. It came unfortunately positive for both the patients. So consultant came, told the 65 years grandpa has angina cardiac, but Messi don't have angina cardiac, it's a false positive. So how can we increase the sensitivity for this renal angina? We can add some biomarkers that can be urine NGAL or maybe some other things to increase the sensitivity or specificity. So study have shown adding urine NGAL to the existing biomarker can increase the specificity at least. And if you can add blood and urine both, then it can also increase the area under curve of sensitivity as well as specificity, but adding to a cost. So you now judge what to monitor, but at least the clinical monitoring are easy. So if you know that a patient having a high risk of RAI on day 1, be cautious to give higher dose of amikacin, try to find other alternative, be happy with some lower ionic contrast, and this step can be taken to simply prevent an AKI. They are simple steps and simple mechanism.
Very well said. So RAI more than 8 is supposed to be having a high risk category, right? So are we following that in our pediatric intensive care or in the nephrology unit? Are we doing that, or like?
Unfortunately, less commonly done.
Less commonly done. But that I think should be done to stratify these patients. Kaushik, any idea about whether we are doing this in our unit?
Unfortunately, no, we are not monitoring the RAI from the ICU perspective regularly. And that is perhaps one of the reasons we fail to predict patients who might develop AKI. So, I mean, if it is done regularly, I think we will be able to predict and take precautionary measures so that some AKI can be prevented in the ICU.
And moreover, if you are combining with, as Dr. Sumanta said, with NGALs, probably we are going to pick it up much in a better way. That's something we are not doing right as of now in our unit. So, right. So again, a lot of been said about the kidney troponins like biomarkers. How do they help in detecting early AKI? So
okay, right. So regarding since the morning discussions for diagnosis of AKI, as Dr. Anil sir and Kadura sir both told, that creatinine and urine output has their own fallacy. They are very good gold standard definitely for age-old years, but have their own pros and cons. So can we define it little bit? So adding some biomarkers that can be functional markers or structural markers. They can be originating from either glomerulus or PCT or DCT, wherever their locations. Problem is they are little bit fancy, costly, and many of them are not yet FDA approved. But luckily, urine NGAL and maybe some of the molecules like nephrochex are already approved by FDA. So we can use them in our day-to-day, at least critical care or selected patient population, where we can diagnose the AKI early. So again, our management will be changing. Only diagnosis is not enough. So our own paper from medical college shows that urine NGAL done on day 1 predict better prediction of AKI on day 3. Not only that, also the fluid overload and also the RRT requirement is also predicted by the urine NGAL on day 1 and day 3. So saying that, we can also get some therapeutic help. Suppose a person having an increased urine NGAL, we can be little bit restrictive on nephrotoxic drug uses. We may try some other alternative, less nephrotoxic one. We can have some of the contrast induced tests which are ICU people's daily choice. We can have some limitation on that, a little bit restriction. That simple steps can be taken after doing this type of screening by these biomarkers. And other than this urine alcohol, which is also available now in India also, there are some bedside tests, point of care tests. Next slide. So that can be a nephrocheck, which is also FDA approved for pediatrics. We can use that. They are combination of TIMP and IFBP. So little bit costly in the initial phase, but as more people get concerned, more people are using it, the price might also get dropped over days. So might be useful for incoming future.
Yeah, nephrology is FDA approved, but I think we are not doing this as of now.
As
NGAL
for
is something that we are
other
doing
than
in
research
India.
basis for India, we are not
We are
doing
not
it
doing it. It's not
very
available.
routinely.
So I don't think it's available. Even NGAL is not available in most of the centers.
Nephrocheck
started
kits is
doing
available
it.
from Biomarkers. It is available in India, but we are only
We
for
are
research
not.
purpose,
So-
only for project study we are doing that.
So coming to furosemide. So what is furosemide stress test and how does it predict the severity of AKI and need for RRT? So many times these children we are using Lasix or furosemide. So how do you predict that? Like how do you classify? Okay, this is the child who is going to go into more severe form.
Okay, so furosemide stress test is basically a test where in a patient where already stage 1 or stage 2 AKI is there. So we are giving a dose of furosemide and we are trying to monitor the urine output for the next few hours. And if the urine output is above a specific cutoff, like more than equal to 2 ml per kg per hour, then on the basis of that, we are classifying like what is the risk of that child in developing stage 3 AKI or the need for a KRT. So this study, which was done from AIMS, had shown. So prior to that, actually, furosemide stress test was validated in adults. In children, there was not that much validation. But after this study, which was well conducted, so it was found that furosemide stress test using 1 mg per kg dose of furosemide in patients having stage 1 or stage 2 AKI, and then urine output monitored over the next 6 hours, and output more than equal to 2 ml per kg per hour for the initial 2 hours taken as the predictive thing, had a very good area under the ROC curve in predicting whether those patients are going to develop stage 3 AKI or any sort of renal support therapy. So yes, this test can be used to predict whether there will be progression of acute kidney injury in case of children also.
But it does not prevent the AKI or further
No,
stages.
so that is
There no
the next
prevention.
point, the question that was asked. So another RCT which was done, it was done from JIPMER in India. So so there were 2 groups obviously. So where it was studied whether furosemide infusion initiated early in comparison to placebo could prevent the progression of the AKI stages. Well, it did not. Although the study had to be stopped because of futility, but the samples which were analyzed, around 37 in each arm, did not show any benefit in use of diuretics in preventing progression of acute kidney injury.
So very often when we were students, we were told low dose dopamine can be something which you can use as a renoprotective and progression of renal AKI. So my question to Dr. Abhishek. So what is the role of vasopressors? What are the vasopressors you use in preventions of AKI? Whether at all you're using low dose adrenaline, noradrenaline or dopamine, what are we doing with this?
No, as we are all talking about fluid overload, one thing which can decrease the incidence of giving more fluids is definitely vasopressors, because vasopressors will not only maintain the vascular tone, it will maintain the mean arterial pressure and it will maintain the renal perfusion. And though low dose dopamine has fallen out of favor, because it has been shown that it literally does not do any help, but other vasopressors such as starting noradrenaline, specifically starting them early to maintain a renal perfusion and a mean arterial pressure, has been shown to maintain the MAP and the organ perfusion, and hence fluid requirement can significantly decrease, and hence fluid overload, which is one of the predictors of the child going into higher degrees of AKI, could be prevented, and early initiation of CRRT can be prevented. So noradrenaline is one of the vasopressors of choice which should be used, and if started, it should be started early.
Right. But the same thing can you say about low dose dopamine?
No, low dose dopamine has specifically been shown that it does not
It does not really help.
It does not help.
So, as per the guidelines, we do not recommend using low dose dopamine, as you said. We do not suggest using even phenyldipam, right? And then not even ANP and BNP. So, there's no evidence to show that renal protection standpoint that is a vasopressor agent of choice to improve kidney outcome. So, this is a second child who is an 8-year-old boy, and then he's coming with fever, nausea, vomiting, weakness, lethargic. There was a muscle cramps, there was swelling of the whole body, there was oliguria child, there's no rash, no hematuria. The child looked pale, there was edema, hepatosplenomegaly positive, BP was on the lower side, hemoglobin was on the lower side, 7.8. And then what you see here is the raised urea and creatinine, 98 and 4.1. There was hyperkalemia, as you see here. The phosphate level was high, calcium level was low, uric acid levels was high, and in the peripheral smear, what we saw was the blast cells. And so, with this kind of clinical picture and investigations, what's your initial impression about the case, and how would you manage this child, Dr. Kaushik?
Okay, so this is obvious to us. It's acute leukemia, like hematological malignancy with like a high risk of tumor lysis syndrome, and probably in tumor lysis already the parameters are deranged. So we must remember that while we manage these patients, as we are discussing here, the prevention of acute kidney injury, prevention is the key goal when we are managing tumor lysis syndrome. Okay, so like when such a patient comes, they should be started preemptively on hyperhydration, and allopurinol needs to be initiated. We need to monitor the tumor lysis parameters at least 3 times daily. And if we are getting rising uric acid levels, we should plan to use rasburicase early. Urinary alkalinization has no role now. We have to monitor the intake output strictly and target a urine output of around 2 to 3 ml per kg per hour. Strict maintenance of intravascular volume. If the intravascular volume is full, rarely diuretic can be tried if urine output is low, but otherwise diuretics need to be avoided, especially if we are not sure or the intravascular volume is not optimum. So we must prevent AKI in a setting where tumor lysis can happen by hydrating early and monitoring closely. That is the main goal. Once your tumor lysis has already happened, then the situation naturally becomes difficult, and that is something which we want to prevent.
So last problem here is that we have a child, Master X. He's a 6-year-old child, known case of steroid-resistant nephrotic syndrome. On kidney biopsy, the child had FSGS. He was on tacrolimus, AC inhibitors, steroids, and then he had a fever and vomiting, for which he was given, for fever he was given ibuprofen for a few days, and then the child developed renal failure AKI, the creatinine being 4.2, there was hyperkalemia. What is the cause here, and how could you prevent this?
Right. So a typical case in our core nephrology. So this type of child has a multiple risk factor already present, particularly a nephrotic child who is treated by polytherapy, mostly nephrotoxic. Suppose tacrolimus, ACE inhibitors, everyone can protect the kidney, but in due course when there is some dehydration, some fever, so that can cause nephrotoxicity by itself. So a simple thing of caution, we can ask the mom, whenever there is some fever, some decreased intake output for 2-3 days, they can self-hold the ACE inhibitors by default and then ask the doctors. Similarly for tacrolimus, if the child is having some of the problem, they can simply monitor the TAC level. And though this is costly, most of the time in India at least, we get it free of cost from our companies who are giving the companies. And for the common pediatrician, okay, many of the time we are not happy with paracetamol for a fever, because if you give paracetamol, you have to get 10 phone calls. You give a simple brufen and your night sleep is okay, but at the cost of patient's nephrological health care. So whenever there is some fever in this background of dehydration, of already getting nephrotoxic drug, better to avoid brufen, be very cautious, and whenever his child is already at this type of problem, you monitor your RFT more frequently to catch the jumping creatinine much earlier. Even the creatinine is caught at 1, that might be helpful rather than caught at 0.4. And most likely nephrotic child, by default, if the child is in relapse, prone to have hypovolemia because they are mostly underfilled, so they are by default prone for AKI. So on this child, on tacrolimus enalapril, better try to avoid brufen for fever. manage with paracetamol and do your RFT more frequently to catch the AKI early.
So the key message is that drug monitoring is very important. Drug review is very important for a child, especially who's a nephrotic, who is on multiple nephrotoxic drugs like AC inhibitors and CNIs, and you're giving an on top of that NSAIDs. So be very careful, and this might land up with something like this. So my last question: how to prevent and manage the contrast-induced AKI? So many a times we as a clinicians order, to do some kind of angiography or something wherein contrast is being used, and that land up with AKI. So how do we prevent that thing, and how can we rather prevent, and alternatives can be used, and if there is any role of N-acetylcysteine or any other drugs can be used?
So I think it's a lot of study done on that contrast-induced nephropathy, and KDIGO already mentioned a special chapter on that actually. But in our setup, we don't see so much of contrast-induced nephropathy. I don't know, probably we miss or we are so not use the contrast actually. So if we think about doing contrast-induced nephropathy from the KDIGO, they are saying just try to avoid the procedure if you have an alternative choice. If you don't have, then you stratify the risk group. If there is a risk, definitely you start the hydration. Hydration there, I used to preferring give the IV hydration by sodium chloride or sodium bicarbonate. And then also change the the contrast, the low osmolar and low volume of the contrast will help to reduce. But then they are not a point against to use of theophylline, dopamine. Even they are not advised to use hemodialysis. This way we can avoid the contrast-induced nephropathy.
So KDIGO also mentions the peri-contrast IV hydration is very important. And regarding nutrition, the most neglected part of our clinical care is that nutrition, especially in this part of the world. So Dr. Sumantro, how do you think the importance of nutrition in prevention and management of AKI?
Okay, so we are with very hurry, and in this hurriness remains in ICU also. So ICU people are busy with ventilators, ECMO, etc., etc. Very commonly missed things is nutrition.
We see everything but not nutrition.
Right. So even if it is AKI or CKD, whatever, right? So day 2, day 3 onwards, we should keep the child on proper energy, calorie, and obviously protein. To remind that this is already a catabolic stage, so we need to have a more energy. The child is not playing football, so resting energy is only enough. The point is to great contrast from the adults where they might restrict some protein. In pediatric, we never restrict it. On the contrary, we can increase the protein requirement because if the child is on RRT, maybe on PD or hemodialysis, the dialysis has a loss of protein. So we need to give to adequate protein, and the energy loss has to be backed up. Otherwise, the child may land up in more mortality. Though the evidence is not backed up, Rajiv sir has helped us to draft this 10 years back, where we proposed that the calorie and energy requirement should be optimal from day 1, day 2 itself, not to ignore by our ICU team or our own nephro team, to keep on that.
So overall, when you talk about preventive approach in AKI, it's a 5-hour approach, rather 6-hour approach now, including the research. You have a risk assessment, recognitions, early response, renal support, and rehabilitations. So overall, general management, early recognitions, avoiding hypertension, avoiding hypovolemia, check your nephrotoxic drugs, treat the cause, and optimal nutrition support. Thank you very much.
So I would request the panelist and the speaker to go to the felicitation counter. Thank you very much.
That was indeed a wonderful panel discussion, sir.
Thank you,
emphasizing a lot on commonly faced ICU problems. So the message is clear that prevention is definitely
better than cure. Thank you.
So I hope I'm audible. Next, we will have a very short discussion on something very interesting, but we often don't deal with it. That is the ethics of AKI, starting RRT, etc. What we have thought of is that we will have a senior person chairing and a senior person moderating the session, and we will present a simple case, and we will have 2 person there as specialists, one from a resource full and another from the resource constraint, and see how it differs, the perspective. So Deblina, if you can announce the name.
Yes. So as sir already said, the next session is an interesting session on ethical dilemma in acute care pediatric nephrology, two sides of a coin. And to moderate the session, I would like to invite Dr. Arun Manglik sir. He is a senior pediatrician. He is the chairperson of the medical legal chapter of West Bengal Academy of Pediatrics and has been the past president of the West Bengal Academy of Pediatrics and the West Bengal Neonatology Forum. And our speakers will be Dr. Ahmad Kadura sir and Dr. Yashu Saini. Dr. Yashu Saini sir is a professor in Mahatma Gandhi University of Medical Sciences and Technology in Jaipur. And the session will be chaired by Dr. Santosh Agarwal sir, who is a very senior consultant pediatrician, and he is also the examiner and nodal person representing the RCPCH in Eastern India. So can I start with the cases, sir?
Please.
So I'll give the first case scenario. It's a 28-weeker, 1 kg male baby. The child was born out of third degree consanguinity and
You can continue.
yeah. So it's a 28-weeker male baby who was born with a birth weight of 1 kg. The child was born out of third degree consanguinity. And because the child was having oligohydramnios, hence the child had to be delivered at 28 weeks by cesarean section. Antenatal steroids were given. In the antenatal USG, there was bilateral enlarged echogenic kidneys at 20 weeks and the amniotic fluid volume was preserved till 28 weeks, after which it decreased, and that's why the child had to be delivered. So then soon after birth, the child starts developing respiratory distress and the child had to be started on invasive ventilation. Surfactant was given, but despite that, the child required continued invasive ventilation. Chest X-ray and lung USG was suggestive of pulmonary hypoplasia, respiratory distress syndrome, and also some pulmonary edema was there. The child after birth remained oliguric with a urine output of 0.2 ml per kg per hour. And the blood investigation showed a creatinine of 1.9 mg per dl. There was metabolic acidosis and there was hyperkalemia. And we did a postnatal ultrasound that showed bilateral enlarged echogenic kidneys with small radial cysts which were arranged in the corticomedullary junction. So with invasive conventional ventilation, there was no improvement, but the child had to be put on high frequency ventilation. And on that, the child's respiratory status gradually started improving. But because of the fluid overload, increasing fluid overload, metabolic acidosis and hyperkalemia, the child required kidney replacement therapy. So there was a need for a kidney replacement therapy. Now talking about the socioeconomic background, the child's father is the only earning member of the family, and there are, apart from the father, mother and this baby, there is another elder sibling. And the father works in a private firm and he hardly earns 20,000 INR per month, which is around $220 per month. So would you kindly address the ethical dilemmas?
Thank you very much. Well, ethics is something very important, morals, ethics, taking care of children when we do. Here we have a situation where we have a preterm who's had multiple problems and the economics behind. As far as ethics is concerned, we need to take care of the beneficents, non-maleficents, and we have to ensure also autonomy. That means the parents decide the final say they have. As far as justice is concerned, because it's an individual patient, that doesn't come up, because that means equitable distribution of resources. So we have two experts here, one from high income settings and the other from our own sort of resource poor settings. So first I'll request Dr. Ahmed to please highlight how do you go about this patient, considering every aspect, the patient care, the benefits to the patient, at the same time the ethical issues. suppose this patient was in your setting and the income profile was as shown, probably there was some support from other places as well, maybe administrative, government, hospital, institution, whatever.
Thank you so much, doctor. So before I go into the ethical issues with the family and to decide if I would recommend or don't recommend renal replacement therapy, I would just maybe ask further questions about how the child is doing. So, so it seems that the child, in terms of respiratory wise, the child is still on high frequency. So that's something. How about like any intracranial bleeding?
No.
No. So how precious is this pregnancy? Is it like the first child?
This
Is
is
it
the
like a
second
result?
child, sir.
That's
And it was a spontaneous conception.
yeah. So yeah, those you know, those questions really very hard. So in my opinion, especially I'm coming from like I work in Qatar. I'm not Qatari though, but the resources there are plenty. So in that case, we believe that there is no child should die because of a renal disease. Okay, I know it is very challenging, 1 kilogram to do peritoneal dialysis, but I would remind the audience that if you look back 25 years ago, like there is an article published by Dennis Geary where he screened the nephrologist about what the minimal weight they can consider peritoneal dialysis. And surprisingly, at that time, they mentioned about 5 kilograms. So those children now, we do 2 or 3 easily, but those children that 25 years ago, they were just left to die without dialysis. So in such child, given that the resources we have, still there is, I see a possibility for his lungs to improve. I see that there is no other cardiac or neurological issues to not to try to help this child. And in this child, I personally would go trying to insert a PD access, maybe a cannula, and 1 kilogram can help. But I would do my best to support this baby.
Just to extend that question, would you disclose the possible adverse long-term outcomes considering the prematurity and the multifarious problems the child is having to the parents to help them take a decision on it?
Yeah, so definitely, yeah. I said about my clinical decision in this child, but this should be done in agreement with the family. I mean, all the potential risk factors, including death, that directly because of the complications of the PD itself, like infection, leaking, all of this can carry the risk, plus all additional long-term plans, end-stage renal disease, liver involvement, all of this, especially if I'm suspecting ARPKD in this child. So yeah, definitely this should be put at in the concept of the parents for sure. It's a not easy decision.
Thank you, sir. So first of all, I would like to thank Rajiv sir for comparing this case with one of the experts from the country whose currency is one of the strongest in the world with us. So it's make a lot of difference. But I would answer that question in terms of these 5 points which sir has raised. First is beneficence. So offering a peritoneal dialysis to a 1 kg child with a weak anterior abdominal wall, the smallest catheter available in our country is also large for that child. So does that PD is doing benefit, or overall it's causing harm to that child? We need to assess. I think pericatheter leaks leading to peritonitis would be one of the strongest or major complications in this child once we start PD, specifically in our settings where sepsis is relatively higher as compared to the developed world. Next, I come to the non-malfeasance, that is do no harm. So are we not doing any harm to that child? Because offering PD is a true benefit, or we are just prolonging the survival of child? Because we need to assess that in our setting, how many percentage of children with a 1 kg weight born at 28 week can be progressed effectively without no secondary comorbidities to a weight of 10 kg and then undergoing a successful transplant. So I think the ratio is very minuscule and it's extremely rare in our settings. Third, I come to the parental autonomy. In our country, we all are aware that when the decisions are being taken, especially for all pediatricians, the parents and the extended family are the surrogate decision makers. So the brains sitting in front of us outnumber our team. We are 2-3 persons as a doctors, and there 15 persons would be standing to take decisions for that child. So when it comes to parental autonomy, we have to respect, even if we are aware that we are just prolonging the survival of child and the outcome may not be a true benefit to that child. And the last would be the legal aspect in terms of Indian context. So as far as I am aware of the legal aspect, no doctor is allowed to overrule the decisions made by the family members. So even after telling them all the possible outcomes, I think the final decision has to be taken by the family. But we should be aware that the counseling is day-to-day basis. So there could be emotionally driven decision making in initial phases. For 1 to 2 days, we might have to initiate PD, but after subsequent counselings, there could be reason where family agrees to withdraw the support. Overall, in our settings, I think the situation is grim and we will not gain much offering PD to this child.
Thank you. And just to extend that, when you talked about autonomy, you have those 10-15 guys in front of you, some of them educated, some of them not that much, and we have this parent, the father who just works in a private sector with 20,000 INR income. Sometimes or quite often you might get an answer, Doc Sahib, you decide whatever is the best for the child. I mean, they just throw the ball in your court. So how do you manage that? Because that is very important. The economics is different. He may say that I'll sell my land, I'll sell my house, I'll sell everything, and I'll do what is the best for the child. Not realizing that this child may not survive, and in that situation, he's lost both the child and the money. He may be leading a starving life thereafter. So how do you manage that? Trying to be more ethical.
Sir, I think answer to this lies is that we are aware that the child needs the peritoneal dialysis at this moment. So in these situations, we would offer peritoneal dialysis to that child. There are many schemes, government schemes also available currently, like Ayushman Bharat Yojana and Bal Suraksha Yojana, etc., which offer money to initiate dialysis, but that has some ceiling. So till that ceiling is achieved, we can offer dialysis, and we do a regular counseling so that parents understand not on the day 1, but maybe on day 3 or day 4, that the outcome of this treatment is not there, and they themselves agree to withdraw the support. I think this is the most plausible and empathetic way to counsel the parents when the ball falls in our court in the situation which you told.
Thank you very much. You'd like to make any comments, sir?
No, I think that's an excellent addition that you made.
So, would you like to add anything? Would you go to the next patient?
I think
We have just 30 seconds for you.
Just for that example, what you've said is all the time the ball is in my side, on my side. The reason for that because economically and how the healthcare system in the country are working is all supported by the government. Okay, so the easiest thing, so they shouldn't take care, you shouldn't worry about the cost of the dialysis, the availability of the dialysis fluids, and even in some conditions, the government will send support to the family in terms of nursing wise. So what you've said is all the time, and the ball is on my laps, because the family really, the only thing they should is caring at that moment is I want this child alive, okay, and economics got it there.
So thank you very much. From your point of view, economics is not the issue, but they must also realize that the long-term outcome may not be as desired, despite the best efforts medically you'll be doing. So Devlina, can we have the next patient? Yeah, carry on with the next patient.
So next is a 4-year-old female who is a known case of Fanconi anemia. The child presented with UTI, with a pseudomonas UTI, and at that point of time an ultrasound was done that showed a left ectopic kidney without any hydronephrosis. MCU was normal, but the child was already having a CKD. The serum creatinine was 0.87, so the child was having like a stage 3B CKD. So the child was planned for bone marrow transplant, and we know that post bone marrow transplant there is a high risk of the child developing AKI. The child is already having a CKD. Considering that the child may develop an AKI on this stage 3B CKD, and there are high chances that the child will require a kidney replacement therapy later on. So we put that case considering that in mind. Father again is a small shop owner who hardly earns some $355 per month, 30,000 per month, and there are 5 family members, including a 2-year-old sibling. So the ethical dilemmas are that the child is already having a stage 3B CKD, may develop AKI on CKD post BMT, high chances of KRT requirement and KRT dependency, and may even necessitate kidney transplant later on. So is it ethical going ahead for BMT in this child considering the socioeconomic background?
Thank you. Wonderful patient. Again, we have got congenital issues, potential for tumors, potential for malignancies, and the bone marrow transplant may help reduce the hematological malignancies, but not the solid tumors. So in this situation, particularly the cost of the BMT would be around $20,000 in our country, and the person earns around $300 per month. So what would be, again, from your point of view, economics is not the issue. Probably there'll be funding from somewhere, and the patient can get it. But despite that, the long-term outcomes, whatever they are, what would be your take on it?
So this child he needs allogenic BMT, correct? And as I said, in terms of economics, how things are go. Yeah. Somebody is what? Yeah, I mean, so it's really difficult to say. So if this child is getting allogenic BMT from maybe sibling who's more than 18 years old, or one of the parents with half haplotype, I would recommend going through the BMT, knowing that in the worst case scenario, we can offer dialysis, so the child will get rid of his, so definitely the BMT will improve the child's life. But if the renal failure happened, given the ablation therapy, the cytotoxic agents, definitely end-stage renal disease is on the list. But the fact that we're supported with the ability to do dialysis, and maybe a future transplant that's going to be a low-risk transplant if the child got the bone marrow from his father or mother who's interested to give the kidney. So I would do this, especially in that situation, because that kidney transplant is going to be almost ideal, and the risk of rejection is going to be less.
Thank you, sir. So this case is a bit different from the previous one, and I would like to summarize my opinion on 3 different points. First is that the path to transplant starting from the dialysis is not very long in this child, as if we go ahead for it, as it was in case of the previous case. Secondary, in case of non-oncological bone marrow transplants, we have a lot of government and private agencies which fund full transplants. Also, the kidney transplant is being covered in the Ayushman Bharat Yojana, and in my state a different scheme is also going on which offers kidney transplants. So as far as our setup is concerned, the only constraint in this case is getting a donor or family's approval to donate a kidney. Otherwise, the child can go ahead for the bone marrow transplant, and if needed, can go for kidney transplant if patient's kidney succumbs. And anyways, if we don't go for bone marrow transplant, the current CKD stage would sooner or later progress, and child would be needing kidney transplant at some point of time. So this case ideally fits into a distributive financial justice of healthcare, where all patients of same disease should get equal amount of financial support from one or the other agency, and it should not be targeted on case-to-case basis.
So the justice aspect of ethics is also taken care of as far as what you have mentioned. Let us not forget one other aspect. Overall, for this child, the running about and the continuous care is to be taken care by the family. Now the father is running about to hospitals, from this hospital to that hospital, getting transplant done, despite the money being spent by Ayushman Bharat or in your situation by the institutions, etc. The person concerned, the wage owner, the wage earner, the person who is maybe he's really wage earner or whatever, he's losing his man days. So he's losing his definite monthly income or a daily income. So here also that will also come into consideration, because that person might realize 6 months down the line that over the last 6 months I've gone to work for the last 2 months only. I've been off duty for 4 months. My salary has been cut off. So that is affecting my finances individually. That nobody will probably take care of. So that issue will also come up later on. Maybe as you rightly said, 6 months down the line, the parent might come out and say, even in the first case, that okay, enough is enough. I don't want to proceed further. And therein, probably we'll have to allow them that autonomy. So,
yeah. So this is an older child than the previous one. So obviously there's been more attachment with the family. So we have a point here to go ahead and treat.
thank you so much. Thanks a lot for your inputs. Thanks very much. We've been very much on time.
Can I make just one comment?
Yes.
I think, look, in these cases, you have to, I as a doctor, when I'm looking at it ethically, and in the purest term of the term ethically, I should be guided by only one thing, and that is the interest of the kid. That is, the interest of the kid should be my primary concern. And when that is so, then things like, funding, I know they are very absolutely practical stuff, okay? Absolutely practical stuff. And it is up to the family to sort it out. And they need to decide how they want to do it. My job is to give them the right information, that this involves this much cost, what is your situation, but I think we take too much of that, and how will they manage it? I think it is being paternalistic, which is a risk that we all become. We all become very paternalistic. How they manage their fund, how they manage their money, it is their job. I am not there to think about that. It is not my job. As an ethical doctor, my job is to suggest what is in the best interest of the kid, and also give them the information that this is the load. How they do that is their job. And if I take a little bit of that job, even conceptually, then I think that is bad. That is bad ethics. And that is, you are being paternalistic. You need to give that autonomy to that family and let them decide.
Thank you. Point well taken. But yes, situations, practically things be a bit different. And I wholly agree with you that paternalistic approach has been there in the medical fraternity for over the years, but things are now changing. And that is why the very question of allowing autonomy to the parents to let them decide on what they want to do. We should not enter into their family and let us be aloof from that. But yes, being human beings, we are not gods. We are all human beings. So at times we tend to feel that probably that fellow is going overboard and he might end up being a pauper after everything is done, and may lose both the child and his resources. So with these few words, thank you so much. And thanks very much, Rajiv, Agni.
Thank you, sir. Sir, I would request you to go to the memento corner and collect the mementos. Thank you so much, sir.
Is an ultra rare disease, and the prevalence basically is higher in children, and in India especially the dynamics is a bit complex, because unlike what is seen in the global perspective, the percentage of anti-factor H associated HUS is reported to be as high as 55 to 60%. Now, atypical HUS is a complement mediated TMA. So basically a complement, we have three sort of complement pathways, of which the alternative complement pathway is where the problem lies here. So it's pathway which is always on, and it is strictly under a regulation. So there are several regulators like factor H, factor I, factor B, and some are positive regulators like properdin. So basically these factors keep the pathway under check, and the activity of the pathway is basically initially forming a C3 convertase which acts and then causes the lysis of C3 to C3A and C3B, and then it forms the C5 convertase which eventually breaks C5A into C5A and C5B. The C5A is actually an anaphylatoxin, so it causes anaphylaxis and inflammation, whereas the C5B component goes on to form the membrane attack complex, which eventually leads to the ongoing cascade of hemolysis, inflammation, thrombosis, and tissue damage. So what we can see here is that if there is a dysregulation of the mediators which are supposed to keep it in check, either by a genetic mutation, which is gain of function mutation of the factors which are supposed to be promoting it, which are C3 and C4B, or by a loss of function mutation of factors which are supposed to keep it in check, that is complement factor H, I, and membrane complex protein, and either there is a polymorphism in the regulators. So all of that is there. Along with that, there is a significant chunk, as I said, of autoantibodies which are directed against complement factor H. So basically that antibody prevents the factor H from blocking the C3 convertase. So eventually what happens is that the cascade keeps going on and it goes into a dysregulated mode, leading to a lot of inflammation and thrombotic events going on, which eventually leads to inflammation and ischemia, produces the classical triad of AKI along with thrombocytopenia as well as microangiopathic hemolytic anemia. Along with that, there are several other organ systems which are affected, which is going to involve CNS and CVS, and it's a multisystemic disease basically. So coming from where we stand currently, 2019 is the latest what we got as a ISPN guideline, where the guideline suggested that whenever you're suspecting HUH, that is, if there is an evidence of microangiopathic hemolytic anemia in terms of having a hemoglobin less than 10, thrombocytopenia, elevated level of cystocytes and LDH, first of all, we need to rule out whether they have a sepsis-induced DIC. So you rule that out. Then you have a suspicion of ADAMTS13. You have to actually, according to the guideline, keep the sample saved to evaluate later on if needed for both cobalamin and ADAMTS13. But because of resource limitation, we often rely more on a clinical parameter. So generally, if you have a severe persistent thrombocytopenia, there is a significant neurological affection, and with mild AKI and mild hypertension, then probably TTP is likely on our mind. Otherwise, by using clinical parameters and scoring like plasmic scores and all, we rule that out. Again, similarly for cobalamin deficiency, we keep the sample, supposed to keep the sample separately and to evaluate for homocysteine levels, which should be low. But then generally, again, there will be a clinical hint towards it. Other than that, if there is a Shigella dysentery suspicion based on the presence of a past history of Shigella dysentery in the 2 weeks time, or there is an outbreak happening, you have to actually confirm it to call it Shigella dysentery associated HUS by either by doing a blood, the culture. Along with that, we have to prove it by showing the virulence genes and Shiga toxins, and or there's a rise of titer. When all of that along with secondary HUS and pneumococcal HUS has been ruled out, then we come to the diagnosis of atypical HUS. Now what to do from here? So according to the guidelines now, you have to send an anti-factor H associated antibody, which is going to be a pre-plex sample. Along with that, you send a complement C3 level, which can be actually low in 40 to 50% cases. And also they suggest that you do a CD46 estimation, and followed by that, you have to go for genetic studies. So all of that eventually, minimum role of biopsy is there, and these guidelines actually now suggest also the treatment in form of, the current treatment is actually kind of focused on anti-factor H antibodies. So we start with PEX initially, as long as we are suspecting and sending the samples, and the PEX has to continue in an intensive phase till we get a hematological remission, followed by gradually tapering it over 4 to 6 weeks time, along with a background of immunosuppression, which should be initially oral steroids, and once the hematological remission is attained, by giving cyclophosphamide with MMF. And then you decide. So what was the evidence behind it, which was a large landmark trial, which was initially published in 2014 in Kidney International, where a group by AIMS Delhi team, which showed a national cohort where 96% of cases proved to have anti-CFH antibodies, and they effectively showed that with the use of PEX, they could reduce the percentage titer by 88% and improve the renal survival by up to 83% compared to 46% in an untreated group, and improve the relapse-free survival. Now, in the recent papers also, in the same cohort that they followed up, and with higher number, the similar rates of survival as well as reduction in the titers have been reported. They have even come up with an abbreviated protocol very recently published in nephrology, pediatric nephrology, where they have shown that even a smaller reduced cycles of 10 sessions of PEX has been working very well. So what is the problem here? So even when PEX we say is working so well, what we have seen in several papers from India as well as on a global perspective, that several of these kids eventually, as high as 25 to 20% to 45% in some series, they land up in CKDs 3 and 5, especially if they have a very high anti-CFH titer, low C3, and there has been a delayed initiation. Along with that, we also know that it is only going to be as much as 40 to 50%. So there is a certain subset of the population of typical CHF who will have basically an underlying genetic cause, which could be GJKE, which could be CFH, complement factor H, I, or complement MCP associated. And in that subset, what we have seen in the pre-eculizumab era, historically, because now globally everywhere it is available almost, other than the underdeveloped countries. So they have shown in the historical perspective that it has not worked very well for them, and a lot of cases have actually had a bad prognosis, especially if it is complement factor H associated, complement factor I, and C3 associated. Even in cases with anti-factor H associated HUS, there has been incidences of frequent relapses and, as I said, progression to CKD. So other than that, there has been concerns related to plasma exchanges, transfusion, dialysis, and transplantation. So eculizumab turned out to be a game changer here. It's a monoclonal antibody which blocks C5, and thus it immediately halts the cascade right there and then. And it is shown to have a very strong efficacy in going for an early hematological remission as well as renal remission. So far it was not there in India, but now it has finally arrived in September, and they have proposed a weight-based management strategy. So what are the global evidences? Several studies have shown a very remarkable improvement in both in the hematological remission as well as renal improvement. Along with that, they have also shown that in the long term, it has proved out to have lower risk of recurrences. So this is one of the papers where they compared 3 landmark trials where early initiation showed that even patients who started with dialysis could be taken off dialysis as much as 83% compared to a late initiation led to almost 0% conversion. And early initiation compared to a late initiation led to a mean GFR improvement of around 57 ml per meter per 1.73 meters square. Initially, it was thought that it has to be continued for lifelong as the defect lies for, it's a genetic defect. But several studies globally showed that if you try to initiate, try to kind of control the initial part of the inflammatory cascade, then you can actually consider withdrawing it. And one of the paper which was Cure HIUS trial, which was from Netherlands, effectively showed that once the child has gone into a hematological remission and the renal remission has been attained and the child has been stable for around a median time of 3 months period. They had stopped and then followed up, and they had a relapse of 22%, but then again early reinitiation could actually prevent the renal damage and take the child back onto the path of hematological and renal remission. Now KDIGO actually also recommends that once you have started eculizumab and the child has been on a stable phase of 6 to 12 months of treatment and 3 months of stabilization of kidney function, discontinuation can be considered. However, you have to have an element of caution because underlying cause also determines the outcome. So you have to kind of see which is the underlying parameter here. And whenever you're stopping, you have to be always on the lookout for features of any TMA recurrences, and that involves training the family accordingly. Now the dilemma or the conundrum lies that whether eculizumab can be or not be used for anti-CSF HUS, because India in a way has a blessing in disguise that the percentage here predominantly consists of anti-CFHs, for which PEX and immunosuppression has been working very well in the past. Whether we actually go to eculizumab or not, several studies have been adding evidences, but there has been a lack of a long, like a good RCT is there. So with the added evidences that are coming up, they are showing that eculizumab can be used. One of the study was Ferry et al., but they used it in a mild to moderate sort of a subset. Another paper that was recently published, it's a case report basically, but they took around 4 kids who had severe AKI requiring dialysis, and they also showed a very good response in those kids. So when you make a comparison, plasma exchange is very good, has been proven over a period of time for a good action on anti-complement factor H. However, it lacks where there is a complement deficiency, where eculizumab actually works better, and there has been a comparative benefits and side effects. Like with eculizumab, especially you have a risk of meningococcal infections, and you need to vaccinate the kids, and relapses otherwise has been reported lesser with a better mortality. So now the recent recommendation which came as an editorial commentary by AIIMS Delhi team, which showed that we actually now, even in cases of anti-factor H antibody, we can actually initiate either the patient on PEX or we can go for eculizumab. They have specifically advocated that if you are going with PEX and the child has a life-threatening event in terms of other neurological complication and other complication, or there are complications relating to PEX, or you identify another complement deficiency in another complement protein, then you should rather switch to eculizumab. Whereas if you're continuing with the eculizumab group and you find that the anti-FHS titers are pretty high and they are really in a bad shape and dialysis dependent, you can actually consider going with PEX. But the background states that there is a immunosuppression that needs to be started, and once the hematological remission has been attained, then you gradually taper off both PEX as well as you taper off eculizumab. Once you can actually consider stopping it once the levels are less than 1000, and then you decide whether it's a CKD 1 to 3 where you continue with the immunosuppression. The immunosuppression ideally should be continued for 2 years, and you keep monitoring the child for features of anthropometry and proteinuria and KFTs, and along with that monitoring the titers, and in the stage of advanced stage CKD actually withdraw the suppression and continue with the supportive management. Whereas in the subset again where you have a pure genetic mediated TMA which is not anti-factor H associated, then you can actually rather switch to eculizumab. And eculizumab however is not recommended in cases like DGK mutation and cobalamin factor related deficiency associated genes. So that's where we stand. This is a good guidance paper which came by the group of Tanvi Vendel et al., where they have summarized very well how to kind of, now that eculizumab is in India, how to use it, what is the protocol, what is the dose that we can follow, what are the specific steps that we need to take. That is, ideally they recommend vaccination to be started from 2 weeks prior, but in a case of emergency definitely we can go with the vaccination along with the treatment. And what we can do here is actually start them on injectable or injectable ceftriaxone or oral ciprofloxacin, and then gradually after 2 weeks switch them to an oral prophylaxis by erythromycin or azithromycin. And in cases of kidney transplant, again you have to risk stratify them and accordingly decide whether eculizumab can be continued or we can go with a milder approach. So there are several other complement factor inhibitors which are in the pipeline, and hopefully the other modalities which can be more effective or easier to apply would be in the picture soon. So currently atypical HUS, as we know, is a rare, potentially life-threatening kidney disease, and actually it comes with a very severe form of AKI, and generally it's one of the worst form of AKI that we encounter in our practices, and its anti-factor H definitely has a higher prevalence in India, which kind of makes it easier to treat with PEX, but along with the emerging evidence of Solaris coming as one of the key things which make a difference in the long-term outcome. Now we have to decide whether we can go with that. There were limitations in terms of the monetary side of it, that it is an expensive treatment, but luckily for us now anti-factor HUS in general has been involved in the rare disease program. So all these center of excellences now have an access of going for Soliris procurement, and we can continue giving it to the patient. Just that how soon it can be done is again a matter of debate, and its efficacy in anti-factor H is to be proven with further studies, and India needs to kind of implement these policy in a more efficient manner. So thank you for your attention.